Lovely. Thank you for that, Mika. Thank you for getting the recording started. And I know this is our last of our series of 7 sessions, so I think we've got quite a lot of people coming to this session, so welcome everyone. We'll just mute people, as if you can either mute yourselves or otherwise we'll just mute people as you come on, just to prevent any feedback. That would be great. Okay, so let's just look how we're doing. Okay, yeah, so I think we're starting to get a good number of people that had signed up attending, so that's fantastic. So I'll make a gentle start. So welcome everyone. Great to see so many people on the call today. Lovely to see some smiling faces and a really good attendance this session, so that's fantastic. This session is hosted by the Department of Communities and Justice, and the purpose is to support DCJ providers in preparing your COVID-19 management plans. And this session is a parallel piece of training, and it accompanies the guidance that was published on Friday on the DCJ website. And Mika will drop that link to that guidance in the chat message in the coming minutes. So before we get started today, I'd like to acknowledge the traditional owners of the land that we're meeting on across Australia today. I'd like to pay our respects to elders past, present, emerging. I'd also like to pay our respects to all Aboriginal and Torres Strait Islander people and communities, and recognising that the services that you provide are obviously working with a lot of those communities across the country. And we also acknowledge the fact that COVID is accelerating at the moment in terms of the number of cases. There's a lot of borders that are opening at the moment. There's a lot of national controls that are starting to come down. And so inevitably, as that happens, we're starting to see higher case numbers of COVID coming back into our communities. And especially given that we have several Aboriginal and Torres Strait Islander communities that have lower vaccination rates than the national average, that we do recognise some of the challenges that are faced by those communities and some of the risks, the increased risks that are faced by those communities. So a very relevant topic for our discussion today. So Mika, thank you for sharing that guidance. So if anyone wants to, you can feel free to click on that and have a browse through the guidance through our session. From a housekeeping perspective, we encourage people to stay on mute whilst we're having a broader sort of chat, but feel free to come off mute at any point in the whole conversation. You can feel free to interrupt us at any time if you've got any burning questions at any point in the session. So the broad structure of this session is we're going to talk about some stuff, and then we're going to break down into a bit of a broader discussion for the second half of the session. So plenty of time for questions, but so feel free to ask your questions as we go throughout. And then, just encourage you to keep your phones on mute and stay focused, and hopefully we'll get more out of the learning that way. So as Mika's just put that slide up there, that's the chat function. So if you just go down to the bottom of your screen and click on the chat box, you can see that. Again, please feel free to put any questions you've got in the chat throughout the discussion, and we'll make sure that we get to all your questions. If there's any that we can't get to, we'll come back to you after the session, but in the previous 6 sessions we haven't been able to get through the chat, so do use that facility. So in terms of the structure for the session today, I'll do some quick introductions of the team on the DCJ side, and Rebek and Justice Connect, who are presenting today. And then Mika from Rebek, myself, and also we've got Dan from Justice Connect are going to be giving a bit of an overview of the guidance and how Justice Connect can provide support to providers. And then we're going to have a series of, open discussions and a few opportunities for any questions that you've got. So, like I say, do feel free to test us. This is our 7th out of 7 sessions, and we haven't had any questions we couldn't answer yet, but do try and test us. We'll welcome everything, and also just I'd really encourage everyone to share experiences. If you found some particular approaches that you've been putting into practice that have worked really well, we've had some great learning through these sessions, through people being quite open to sharing some of your good practice. So really appreciate those learnings. Okay, so if I move to introductions, I'll briefly introduce myself and Mika. So my name is Jay Rebeck. So I run Rebeck. We're a healthcare consultancy based in Sydney, who works across Australia, and really, our core purpose is to help reshape and improve healthcare to improve outcomes for people and communities. So we've played a really big role over the last 3 years working with DCJ. I've really enjoyed working with DCJ and providing support to providers that DCJ commissions. And for the last 18 months throughout COVID, we've been providing a range of COVID guidance to support DCJ's providers. We started off with guidance that we provided all the way back in sort of April, May last year, around COVID support for specialist homelessness services and out-of-home care, which we then refreshed earlier this year. And then bearing in mind there's been a request or I guess feedback from the sector that they'd really appreciate a bit more guidance about how to develop your COVID management plans, and specifically the risk assessment component. We've been involved to do this piece of work. So it's this guidance that was published on Friday, and this range of seven seminars that we're running. So Mika, if I could get you to introduce yourself also from Rebeck.
Hi everyone, I'm Mika Kato. I'm a senior consultant with Rebeck. And I am a project consultant on this particular project. I've helped to develop the guidance, so I was in a range of consultations with the peak bodies, so I can see some people who I spoke with during those meetings, and in our conversations with the peak bodies, we talked about some of the guidance that is being put out, some of the resources that are available, as well as some of the considerations around clients and workers and operating environments that are important to sort of each of the areas. So I hope you find this guidance useful, and I hope you have a great session today. Thanks.
Thank you, Mika. And Sophie, if you could introduce yourself and the team, that'd be great.
Okay, hi, Jay, and all. Thank you very much for coming along today. I'm Sophie Holloway, the Director of Policy and Practice in Partnerships, and it's our area that has been working on the COVID-19 management plan, management and vaccination policy, and working on joining with Jay, Justice Connect and Peaks in providing this series of webinars and some resources. So it's fantastic that we've got a lot of people joining us for this general session. It's great to have you here, and hope that you feel free to ask many questions and join in the discussions as we go along, because the previous 6 have been very useful from that perspective. Today with me I have Michelle Dowd from my area, who is the Manager of Commissioning Policy. Michelle, I'll get you to introduce yourself, and then after that we've got a couple of other people that need to also say hi from DCJ.
Hi everyone, I'm Michelle Dowd. Nice to see so many people here. As Sophie said, I work in the team that's been leading this work on the policy and resources around the plans. I think we've got a couple of program area people here today. So we've got Cassandra. I don't think Deanne Smith is here. There might be...
I think Belinda's here too.
Belinda's here. So if they'd like to introduce themselves, our fellow DCJ people from the program areas, that would be great. Thanks.
I still can't hear it. Why is it not working?
Hi everyone, I'm Cassandra Canitz. I'm a senior project officer on the project and change team in housing, homelessness and disability. That's right, yeah, Deanne won't be joining. She's got another community of practice that she'll be attending later. And yeah, we've been involved in the development with REBEC of the SHS guidelines, the COVID-19 guidelines. So yeah, good to be here and looking forward to hearing about the discussion.
Hi, I'm Belinda Redwoods, the Director of the Out of Home Care Program, and very happy to be here and participate, and have been involved in a number of different discussions over the last few months, I suppose, around responses to COVID and how that impacts on foster carers, particularly, and children in care.
Wonderful. So welcome to DCJ team. So yeah, Belinda, Cassandra, Michelle, Sophie, and Dan, if I could get you to introduce yourself from Justice Connect, that'd be fantastic.
Thanks, Jay. Nice to be here. Hi, everyone. I'm Daniel Komisarov. I'm a lawyer at Justice Connect. Justice Connect's a social justice charity and a community legal centre. I'm in the not-for-profit law program of Justice Connect, where we assist the not-for-profit and charity sector. We've been very busy over the last 18 months producing lots of support to the sector in relation to COVID-19 through fact sheets and FAQs and free webinars some of you might have attended. We've been invited today by DCJ to field sort of legal questions that come up throughout today's discussion. As a lawyer, I need to explain that I can't give legal advice on the fly, but a little bit later I'll speak about how you can access that one-on-one tailored support from our service. But really nice to be here.
Great, thanks, Dan. That's fantastic. And the first question coming up through the chat. So Naomi asking if we get a copy of the PowerPoint slides, and so yeah, Mika's just put a link on the website, so you'll see all the PowerPoints for all the previous sessions are already there. And then probably if you want them for this session, probably the very first one that we ran is the most similar to this one, but then the slides from this session will also be made available later today. As well as a recording of this session if you wanted to relook at it later or indeed share it with any other colleagues. So I'll just say a few words about a bit more about the objectives of the session today, and then I'll hand over to Mika. So as I mentioned before, this really came out of the fact that DCJ ran a survey several weeks back asking if the sector would appreciate a bit of additional support around how to develop the risk assessments and COVID management plans. And the answer was a fairly resounding yes. There was around 350 providers who responded saying that they would appreciate a bit of additional support, and particularly acknowledging that while some of the larger providers or national ones might have a bit more resources, some of the smaller providers in particular may not have quite the level of resources for some of these activities. So hopefully this set of guidance in this session is supportive for the range of providers that are looking for a bit of extra support. And the first thing to note is that the COVID-19 management plan isn't in itself a product. There is no template for the COVID-19 management plan. What there is three constituent products that make up the COVID-19 management plan. So those three products are firstly the COVID Safe Plan. Mika will go through that in a little while. And there's also the Business Continuity Plan, and then there's the risk assessment. Now, where the particular feedback we had from the sector was that the risk assessment in particular is what people would appreciate a bit of additional guidance and support on. So you'll see that the guidance that we're going to take through today and is in the materials in the chat gives you a bit more of a detailed breakdown of how to complete a risk assessment. The other thing I'd say is that we have consulted quite closely with all of the key peaks who support DCJ providers. And through that consultation, we've been able to elicit many of the existing risks that exist for your services, and also many of the controls are all already been put in place. Now, look forward to hearing more feedback from the discussion today, but hopefully a lot of the synthesis that we put into that guidance should provide some really good, thoughtful, starters of things you need to consider. So that's really the overall plan and the three components. The key objectives for today, firstly, is that we're going to just spend the first 15 minutes just stepping through the guidance. Then we're going to have several questions that give us an opportunity to apply the learnings based on your real world experiences. And the first thing to note is that you are the experts in the delivery of your services, and you've been managing COVID-19 for 18 months already. So you already have put in place a series of controls and measures. And so we recognise that. We also recognise that now is actually a really good time to be refreshing your plans. It's a really good time to be reconsidering. I think as borders are opening, we are going to see case numbers rising, particularly before we get really high vaccination rates nationally. And I think we only have to look to Austria and Holland, which have only sort of 65% and that sort of level of vaccination rate, particularly in Austria. And they're actually starting to have to go back into lockdowns again. So nobody can predict the future, but what we can see is in other countries that have opened up very broadly with those slightly lower vaccination rates, you do sometimes see significant outbreaks re-emerging. So we need to be alive to that. And also we're moving into summer, so lots of activity and movement. And the other thing to mention is as we start opening up international borders, particularly, as well as allowing COVID, or not deliberately, but there will be more transmission of COVID into the country, inevitably. There will also be more other infectious diseases, such as the flu, that are going to start to circulate. So it is a good time now to be reflecting on the risks that you've got in COVID and thinking through preemptively before any outbreaks might happen, how you might, what plans you can have in place so that if and when something does arise, you're ready to go. And then the other two objectives that we've got here are really just about making sure that this is an interactive forum. So really happy for people to ask as many questions as you've got, share your experiences. So really, we always find it helpful for people to share experiences of maybe what's not worked very well or what's worked brilliantly well. Either way, really welcome that kind of sharing environment today. So if we move on, I'm going to hand over to Mika, who's going to talk us through just some of the key aspects of the guidance. So over to you, Mika.
Thanks, Jay. So I'll just start off briefly speaking about the scope of the guidance. So to begin with, we've got the guidance does not. So the guidance does apply to service providers that have been contracted to provide their services on behalf of DCJ. However, like it says in the policy, it does not apply to organisations who receive grants from DCJ. In this guidance document, we do provide an Excel template for the risk assessment. And we also do provide a range of examples from other providers who have been willing to share their risk assessments or other documentation with the rest of the sector, which is really useful just to have a look and see how your plans compare. And we also do share a range of resources. So as I mentioned before, we have consulted with the peaks who have already been involved with this for a while now. So they've maybe developed their own resources or they've been sharing other resources with their providers. So we've tried to bring that all together within the guidance document. However, as Jay's already mentioned, we're not asking providers to complete new plans. If they've already been completed and they meet what's required in the policy, we're not saying, go back, start again, put your plan into our template. Nothing like that at all. Just it's there in case you need it. And this guidance is there in case you need some help thinking through those risks and considerations for COVID. And finally, this guidance does provide some considerations for legal questions. And as we know, Daniel's on the call today. So if you do have questions for that sort of legal area, he might be able to help you out. But again, this guidance won't be providing specific legal advice. And I'm sure, as Daniel will mention again, there's ways in which you can get in touch with Justice Connect or ask for more specific legal advice for your organisation, as we know that all organisations are different in the services they provide, as well as who they provide to and who they work with as well. So I'll just move on to the overview of the structure of the guidance document. So we start up the top in chapter 2, talking about what is involved in this COVID-19 management plan. as referenced in the DCJ policy. So there are those 3 plans that Jay's mentioned before: the COVID safety plan, the risk assessment, and the business continuity plan. So the following chapters after that are about workers, clients, and operating environments. So obviously each provider is going to have a different range of workers and clients and operating environments that will have an effect on the risk factors that need to be considered, as well as the controls that need to be considered to be put in place to try and prevent those risks or to deal with those risks when they do come about. So some examples of workers that you would be considering is the difference between contractors versus full-time employees versus volunteers. In terms of clients, you'd be thinking about clients who are from particular groups of people. Maybe they might be from Aboriginal and Torres Strait Islander background, people might be from cold communities, and then also other things that may have an impact on the way you put controls in place. For example, clients living in a remote area or of a lower socioeconomic status. And then finally, we talk a bit about the operating environments, which can include face-to-face, and that might be within your own premises where you have control over the environment, or external premises where you may not, for example, going into somebody's home or going into a supermarket, and then thinking about what kind of things you'd need to consider in terms of remote working environments or being in a residential facility as well. So I think I'll pass back to Jay for the next slide.
Lovely, thanks for that, Mika. So in terms of the overall legal considerations, so Dan's going to answer any questions and provide more information on this in a few minutes. But at a high level, one of the most important bits of legislation that needs to be considered is the Work Health and Safety Act. So one of the key aspects of this for you to consider, and there is an obligation that rests with you as providers, is to minimise the risks to health and safety as far as it's reasonably practical. So a really important point behind all this guidance is that DCJ is not actually asking you to do additional things above and beyond your existing legal requirements. It's literally just providing guidance about how you can adhere to all this guidance in a really structured way. So the reasonably practicable point is a really important one, because it does mean that you need to be identifying, assessing and minimising the risks as much as you can, and taking the highest level of precautions that you can that are reasonably practicable. So I'll talk more about that in a moment. The other important aspect of the Work Health and Safety Act is it does make a general duty of employers to consult with workers on all safety measures. So this is really important because you may have consulted with workers when you first put together your protocols for dealing with COVID. But if you were to change those protocols or change the controls in any way, and that might be in response to, say, an elevated level of COVID in your community, or you having a suspected or confirmed outbreak, or a range of other reasons, then if you do change the controls significantly, then you do need to consult workers. And a really good example of this is your vaccination status. So if you, for example, it has been optional, and then you decide to move to mandating vaccination in your premise, which is an option that you could take. And we could talk more about under what circumstances you may or may not choose to do that. But if you do choose to do that, you do need to consult with staff members as part of that process. So that consultation is really important. So when we look at reasonable practicability, that's a really key test that you need to be thinking through. And it refers to the highest level of protection in the circumstances to eliminate or minimise the hazard or risk. Now, I'll talk about the hierarchy of controls in a little while, but in broad terms, what it says is that there are a range of activities you can put in place, such as completely separating people, which has the highest level of control, and it's the highest level of protection against COVID. And the thing to remember about COVID is a disease of proximity. So at its heart, wherever you see COVID, most prevalent, it's where people are coming into contact with other people, and it's no surprise that a lot of the outbreaks have happened in, high density living areas, whether that's in tower blocks or social housing. And so if you can keep people apart from each other, then obviously you can really reduce the risk of COVID. But the key point is it's not reasonably practical to always do that. Given the highly sort of sensitive and important work you do with some really vulnerable populations in DCJ, then it's just not reasonably practical for you to be doing everything, via Zoom. So that's why the hierarchy of controls we talk about what is reasonably practical for you to still be able to deliver the service. And so DCJ are definitely all about inclusiveness and about trying to maintain service continuity and deliver your services to the often quite vulnerable people that you work with in spite of COVID-19. So that's that balancing act, which we can talk a bit more about through the session. Now, there's other legislation as well to be aware of. So work health and safety is clearly really important, but you also need to be across public health orders that may or may not apply to your particular geography, to anti-discrimination law, privacy law, industrial relations and workplace law. So again, whilst I think hopefully for this session we'll be able to answer most of your questions from a legal perspective, you can imagine the complexities do sometimes add up because you might have multiple pieces of legislation that might bear upon a particular COVID control that you're trying to put in place. But hopefully that's a bit of an overview of some of the relevant legal considerations. And so, I'll hand back to Mika, who's going to talk through a little bit more about some of the COVID plans themselves.
Hi, yes. So as we've already mentioned, the COVID-19 management plan is made up of these 3 plans in blue. And in addition to that, we have the list on the right-hand side. So as it says in the little orange box down the bottom, if you've already got those 3 plans in place, they can be considered your COVID-19 management plan. You don't have to do them again. If you don't have them in place, the guidance will help you to create those plans. On the right side of the page, we have other requirements that are included in the policy, and these are the processes and activities that also make up part of the COVID management plan. Super likely that you've already got these processes in place. So, for example, respond to a confirmed or suspected case of COVID-19 in the workplace. So you want to have a documented plan of how you would do that response, who would be involved, who you'd need to communicate with, what the actions would be, and how you would resolve and continue to go on with your business. So it's important to make sure that these are documented and shared with the relevant people. So whether that be your workers, especially, and also your clients, so that everyone is understanding, what would have to happen next should one of these incidences occur. So I will talk about the COVID-19 safety plan, and then Jay will talk you through the risk assessment and the business continuity plans. So the COVID-19 safety plans, again, likely that you will have already completed this. So if you haven't, you need to visit the New South Wales Government website. And when you're on that website, there's a whole list of industries that you can select. So you would select the one most relevant to yourself, and you would fill out that COVID safety plan using that online template. You will also have to register as a COVID safe business as well. So the main thing about this is keeping a copy of your plan available to present it to somebody if they ask for it. But again, as I mentioned, if you've already got this in place, then not necessary to do it again. However, if anything has changed since the last time you did that, it may be worth considering revisiting it and seeing if it does need an update. So I'll pass on to Jay now for the risk assessment process.
Yeah, lovely. Thanks for that, Mika. And I think particularly if you are refreshing or reviewing your risk assessments or reassessing the risks, the COVID risks that your organisation is facing, then exactly as Mika was saying, that the process of thinking through that may well mean that it's a really good time to just refresh your COVID safe plan and also the business continuity plan. So if we look at the risk assessment cycle, so again, what we've done with this guidance is just try to distill good practice. So this will be for most of you hopefully really quite familiar territory. And I think where the value that we've added is really just trying to simplify this process as wherever possible and just distill some of the insights and wisdom from the sector into some of those really key, make sure you've thought through what key risks and controls that you could put in place are. But the risk the risk assessment cycle really starts with identifying the hazards. So it's really just systematically thinking through the types of people using the service, people delivering the service, and the environments that they're working in. And given those range of factors, what are the hazards that might exist? And one of the key things that we encourage in this guidance is that for each different service setting that you might deliver your service in, so you might have some office space, it might be have some residential facilities, even some services have like community services delivering out of vans and stuff. And there's a whole range of different service settings. And just recognising that the fundamental nature of COVID is different depending on the different service setting. So really encourage you to think through having like a separate risk assessment for each of those different service settings. And again, just so it doesn't sound like it's too much work, when in practical terms, it's an Excel spreadsheet and it's a separate row on it up for each of those service settings on the Excel spreadsheet. So again, the tools that we've provided, which again, you don't have to use, but if you haven't, or if you've got processes that you're not finding are working well, you're welcome to use those. And we have done them so they're quite fit for purpose. So that's the first step, identifying hazards. The second is then assessing the risks. And again, this is standard good practice around risk assessment. So we're talking about identifying what the severity of the risk. And obviously, as we know with COVID, it can be pretty severe. Catching COVID can lead to hospitalisation and death. So that's pretty some quite high severity risks we're dealing with here. And then you look at the likelihood of the risk coming to pass. And then in time-honoured fashion, essentially all we're doing is then multiplying those two things together in a risk assessment matrix, which leads to a set of criteria or guidance as to how critical it is to address that risk, which helps you to prioritise which risks you need to put controls in place. So that's the risk assessment process. And again, key point to note there is that the likelihood of the risk coming to pass is clearly going to vary over time as broader situation changes. So again, as we're in a situation, as I mentioned at the beginning, where we're actually opening up borders and where there's actually more COVID that's essentially being allowed to creep into communities, then we know that the likelihood of COVID happening is generally increasing, although noting that is significantly diminished if you've got a community with very, very high vaccination rates. So you've kind of got two factors going on here about one that's leading to more COVID and the other one that's obviously mitigating. So depending on the particular vaccination rates and level of COVID in your local communities, that's clearly going to affect the likelihood of some of these risks coming to pass. The third component of the risk assessment is the controls. So this is basically what are we doing to address those risks. And the fourth, a really important point, is about making sure that we're then reviewing and maintaining the controls. So are the controls that we've got in place working? Has the environment changed? Do we actually need to reconsider? And again, a really good conversation that came out of one of our conversations yesterday is just recognising that we're getting a bit more sophisticated in our approaches now, recognising we've been living with COVID for the best part of 18 months, where it's not really just it's not a set and forget with COVID. You can't just say, right, we've got these controls in place and that will always work. It's sometimes we have to put in place slightly increased controls as potentially, we might have high levels of COVID in our communities. And then as we get higher vaccination rates and particularly as COVID rates go down, then we potentially can bring the controls down. So it's not just like a set and forget. We may need to update our controls as the environment is changing. So that's really the important fourth point of the risk assessment cycle.
Please.
Lovely. Okay, and so if we just move on to the first of these, the identifying hazards. Again, as I sort of touched on this previously before, but the key things to think about are who's delivering the service, so what types of workers do you have working for you, and who's using the service, and then how they're interacting. So at its heart, those are the key things to think through. So from a worker's perspective, we need to think about both paid workers and unpaid workers. And we need to think about employees, contractors and subcontractors, as well as any consultants that you may have, volunteers and students. And again, students can include apprentices, trainees, and those are work experience. So we do have obligations for, on work health and safety to make sure that we have considered the risks and put controls in place for all those types of workers. And again, we need to be quite broad in the types of clients that we're thinking about, because this can be individuals, groups, children, young people, and it can include families of clients. It could be tenants, and it can even include members of the public. So that's quite a broad range. And then in terms of operating environments, as I mentioned previously, it's really just thinking about how are people coming together and in what environment are they interacting. I've seen there's a question. So Graham was just asking, is there an editable template that can be used? Absolutely, there is. So the risk assessment templates, we provided an editable Excel template on the DCJ website. And Mika, if I could ask you to drop that into the chat so that that's easily accessible to the group, that would be fantastic. As well as I see you've already put the guidance as well. Lovely. So that's the first step of the risk management cycle, which is identifying hazards. If we move on to the second step, so as I sort of mentioned previously, what we're thinking through with our risks is two things, which is, one is how likely is it this risk could become an issue and actually eventuate, and the second consideration is what's the severity. So if this risk were to become an issue, how severe? And once you think through whether this is very rare or almost certain, and then on the likelihood side of things, and then whether it's an insignificant or an extreme risk, when we add those together, that gives us this kind of overall assessment of how critical it is that we address this risk and how urgently we need to address the risk. So it's just a really helpful way of prioritizing our risks. So that's the approach. And as I just mentioned, so Mika's very helpfully just put the risk assessment template link in the chat. So if you go into the chat, you can fish that out now, and you can see that that Excel template, you can just literally start going in and use that for your own purposes now. And so everything that we talk about now is it's summarized, and there's an editable template for you to use there. So that's the risk management step 2. So if we then move on to step 3, and again, we've stepped this out in the template itself. This is where we get onto the hierarchy of controls, which is the issue that I touched upon at the beginning of the session. And as I mentioned, when we think about what's reasonably practicable, depending on the nature of the service that we're delivering, we will depend what is reasonably practicable, but you should always strive for the highest level of control that's possible. So if there was literally no downside whatsoever and it was reasonably practicable, then clearly the best way of reducing risk is to eliminate the hazard altogether. So given the hazard is other people, if we can eliminate interaction between people and actually get people to, for example, have Zoom meetings like we're having now, then clearly our risk of COVID is eliminated. So that's great in terms of reducing health and safety risks, but not so great recognizing that we work in a real world where we're working with some really vulnerable communities and individuals where actually we can't deliver the service in a reasonably practical way through Zoom. So there are lots of examples where we have to be face-to-face with individuals and clients to be able to deliver the service effectively. So therefore, where it's not reasonably practical, we then work down to the next level of nature of controls. And so in this instance, with the hierarchy of controls, you've got substitution, isolation, and engineering. So substitution is essentially reducing risk by doing things by replacing hazards with alternatives. So a good example is if you've got lots of shared accommodation, then you might move to single room accommodation. Again, that may not be feasible. You may not have the space. You may not be able to afford to, but it's certainly an effective, highly effective control if it's possible. And the next is physically separating from the hazard. And again, in this instance, that's potentially plastic barriers between clients and workers. We'll have all seen that as we go around supermarkets. I'm sure many of you have got a lot of these types of barriers in place in your premises. And again, just thinking through the architecture and the design of the spaces that you're delivering services in, to just find a way of actually trying to minimize people congregating together, for example, in queues and things like that, where it's not necessary. And if there are better ways of actually designing the space so that you can actually keep people apart from one another, then that's a really good control. And the next is around engineering. So a really good example of engineering is potentially if you're in an office setting, you might try and have the windows open. If you've got ventilation, trying to get appropriate filters in place to try and prevent COVID from actually being transmitted across different rooms in a building. And then working down to the next level, we then think through some of the administrative and PPE kind of controls that are in place. So from PPE perspective, we'll be familiar with the range of masks, face shields and gowns that we have in place. And again, had some good discussions earlier in the week about some sort of more lightweight PPE that's used in some places. Some organisations have been using that's been really quite fit for purpose in some of the settings they've had to help keep people from catching COVID. And then other things like QR code check-ins and things like staggering shifts and trying to prevent workers from actually working across multiple sites if it's not necessary. So some of those kind of administrative and PPE things are other controls to put in place if you're not able to put some of those higher order controls in place. So that's the risk management cycle. And then as we move on to the final step, so as I sort of discussed previously, really important that we're regularly reviewing and maintaining controls, that we've got the appropriate processes and governance in place, that from the board of the organisation all the way down through the organisation, so that we're constantly horizon scanning to see what the context is, how the context might be changing, and then making sure that the level of controls that we're setting as appropriate is proportionate and appropriate to the level of risk that we see in the environment. And so you can see that acknowledges the fact that you may need to update those controls if the environment changes, or indeed it might be that there's a change in public health advice or some other external change that might cause us to have to adjust our risk management cycle. But critically, just even in a steady state, we just need to, particularly we're living in an era at the minute of heightened risk with COVID, and it's a vicious disease that I'm sure any of you have had friends or relatives, or indeed if you've caught it yourselves, you know what a horrible disease it is. And it's really important. And I think on that note, I'd mention, we were sort of asking earlier on a call we had a couple of hours ago about what are some of the biggest risks in the coming months. And one person put in the chat, which I thought was interesting, they put complacency. So actually complacency is a bit of a risk. I think it's a really good point that at the minute we've been living with COVID going up and down and in and out of our communities for so long that there's a lot of fatigue. I mean, we're actually training on COVID, and I think we've been talking about COVID a lot for a long time. I think lots of us are all feeling pretty fatigued with COVID and would wish it could just sort of stop existing, but it is still here, and actually we are going through a period of heightened risk in the coming months. So however frustrating and fatigued, it's really important we remain really vigilant and don't get complacent in the coming months. Okay, so if we just move on. So what we've done, and this is the template that Graham was just asking about, that Mika's put that link in the guidance to. The template in Excel, essentially, it takes this flow diagram, and there's essentially a column on the Excel spreadsheet for each step on this flow diagram. And as you can see, we've actually developed each column to essentially mirror onto this 4-step risk control cycle. So we've tried to make it as logical as it can be. So really the first 3 columns are really just thinking through identifying what is the service setting. And as I mentioned, just having a separate row on the spreadsheet for each of the different service settings you've got. And for each service setting, it's thinking through, okay, who's delivering the service, so which workers, client, who's receiving the service, operating environment, how's the service delivered, and how are people interacting with one another. And so depending on those 3 things, you'll have a range of different risk factors that come out in those different service settings. And you'll also have a range of existing controls that you already have in place. So that's what we get you to think about in terms of identifying the hazards. Then when we move into actually assessing the risk, what the spreadsheet does, it just helps you just work through the likelihood and severity, which leads to a calculation of the overall urgency. So again, that will just help you prioritise your risk assessment. And then from that then gives you another column to then assess what are the most appropriate controls given the nature of the risks you've got and the urgency of addressing those, which will lead to an agreed set of actions, controls that we then put in place for your organisation. And then the final step is, as we talked about before, is just getting you to think about how often you're going to be reviewing those controls and then adjusting them. So hopefully that should be really quite familiar territory and quite useful. Okay, so I'm just going to take a question here before so it's good to take questions as they come up. So Fiona has asked a question. We're getting inquiries from potential and existing volunteers that are not vaccinated, do not want to be vaccinated, but are or want to work in DCJ funded programs. What is the preferred link we can send them to get more information from DCJ? And I guess there's two different considerations here. There's some kind of some legal considerations to this, and then there's DCJ guidance. So Dan, do you want to go first, perhaps? And then Sophie, do you want to follow up with the DCJ perspective?
Yeah, thanks, Jay. And thanks for the question. I think that question around volunteers is a great one, and often a type of worker that isn't discussed in the same way. There's not as much guidance about the volunteer. The starting point with volunteers is thinking from the organisation's point of view is, would our volunteers be subject to a mandatory vaccination order under a public health order? Most of the public health orders are drafted in a really expansive way that includes volunteer within the meaning of worker. Where that's the case, where you're a provider that is subject to the mandatory vaccine requirements under a public health order, and that includes your volunteers, it's non-negotiable. It's a really straightforward situation. They can't volunteer with your organisation if they're not vaccinated. Where a public health order doesn't apply, it's a work health and safety assessment. So we have to think about a whole range of factors to think about whether mandatory vaccination is necessary for our volunteers. So what setting would the volunteer be working in? What does COVID transmission in the community look like when at the time of their volunteering? What are other safety measures we have in place? What is the advice from government, including, our funding body being DCJ? And if after assessing all those factors, the organisation comes to the conclusion, you know what, we have to mandate vaccination for our volunteers, then unfortunately it's a situation where the organisation needs to go back to the volunteer and saying, we'd love to have your support with our organisation, but at this stage we are adopting a mandatory vaccination position for our volunteers. The only exception to under the public health order and a work health and safety assessment is managing anti-discrimination laws. So people have very valid reasons for not being vaccinated where they have an existing medical condition. So in whichever mandatory position we adopt, either through a public health order or through our own assessment, we need to have carve-outs for people who might have valid reasons for not being vaccinated, and potentially coming up with volunteering roles that are safer for them to perform if they're unvaccinated. Sorry, it's a bit of a long-winded answer.
That's fantastic, Dan. And yeah, Sophie, if you've got anything to add to that.
Thanks, Jay. Look, Daniel, I think you sort of really answered the question in terms of what you do from an organisation's perspective. That it goes to the crux, I think, as Dan indicated, to the risk assessment and looking at the different types of settings that volunteers might be needed, and do those settings actually, is the control that's required for work health and safety, is it vaccination or not? Interestingly, at a former session, there was a discussion between some providers, and one where they had indicated they had actually made it mandatory for their staff and volunteers to be vaccinated, and they were going down that path. But then in the same sort of session, there was another provider that said, well, no, they've gone the other direction and said they wouldn't mandate vaccination, but that they were using a range of other PPE controls. And one of the things I think that they mentioned was that they treated everyone as if they had COVID. And so we're using PPE or other controls like meeting outdoors, masks, that kind of thing. So at the end of the day, it comes down to your risk assessment and what seems to be right, as Dan said, in terms of your particular operating environments. I guess the one difference, so that's for your programs. Where you might have a program though, where you may have to come into a DCJ office, or if you're co-located in a DCJ office, you would have probably have received some advice from us that DCJ has made it mandatory for all staff to be vaccinated, both frontline and office-based staff. And if anyone is co-located or has to come into an office to provide services or work alongside a DCJ worker, people need to be vaccinated. So in those circumstances where it's the DCJ policy that basically applies, so for its own staff, those circumstances, that would be another circumstance where, you know, if that happened, and I'm not sure that it would very often, you know, the volunteers would need to be and staff would need to be vaccinated. But by and large, if it's in different settings in your own business, you would need to be looking at what makes sense in your own for your own health and safety of the volunteers and workers.
Lovely, thank you for that, Sophie, and thanks, Dan. And Fiona, I see you've sort of had a follow-up question about what the best link would be for the public health orders. And Dan, thank you for just putting that link to the public health orders from the Health New South Wales website. Much appreciated. So yeah, keep questions coming as we go. It's really helped, really good discussion. So if we move on, Mika, as we talked about, there's these three components or products that make up the overall COVID-19 management plan. And the third of these is the business continuity plan. Now, the business continuity plan, again, through the consultation that we did, we recognised that all organisations have their own business continuity plans, a range of different templates that you've been using for over many years. And so we're not asking you to kind of copy and paste your current business continuity plan into some new format or anything like that. That's not necessary. But it is important that you do have a business continuity plan in place. So for those of you that already have business continuity plans in place, then definitely encourage you to revise and refresh them and make sure they're up to date, particularly if you're using this opportunity to update your risk assessment settings. But for those of you that perhaps don't have a business continuity plan in place, then we'd recommend that the New South Wales Small Business does have an excellent business continuity plan template, which includes COVID-19 risks and a range of other risks, including fires and floods. And again, perhaps if I could ask Mika to drop a link to that in the chat, that'd be fantastic. And that is, a really good template to use if you haven't currently got a business continuity plan in place. So that's the BCP. And then if we just move on to the next slide. So one of our sort of key principles in developing this guidance was that we recognise that you've been delivering in a COVID environment for 18 months already. And so we know that you've got lots of experience about how to do this. You've already put lots of controls effectively in place. And also the peaks have really stood up to the challenge in terms of already putting out lots of guidance. So one of the key things we were keen to make sure was that the guidance that we've put out is standing on the shoulders of giants and actually is consistent and supportive of the previous guidance. So you can see the range of peaks that have been involved with our consultation, and there's a whole range of other frequently asked questions, seminars, webinars, things about, AQUA, for example, emergency staffing options. Centre for Volunteering's put out interesting guidance. And I won't list them all out, but there's just some really, really good resources in there that answer some of the specific issues. And I think the final point I'd add is that on Justice Connect's website, so Dan's organisation, there's some really good frequently asked questions to support community organisations and social enterprises such as yours. And so, Dan, on that note, I'll hand over to you. And if you could perhaps just talk a little bit more to the support that you provide generally and specifically to those organisations that need
Yeah,
it.
sure. I've just posted a link to our FAQs. So based on the inquiries that we get, we try to pick out sort of the common themes and respond to them in a way that's accessible for everyone. But of course, as you go through this risk assessment process, you're likely to engage with a whole number of areas of law, being privacy considerations or anti-discrimination law, or even contractual obligations. So you are welcome to look at our legal advice page. We provide that direct tailored one-on-one legal advice to community organisations. We of course have to have eligibility criteria and prioritise support for small to medium-sized community organisations that can't pay for their own legal advice, but I'll drop a link to our advice page for you to review our eligibility criteria and invite you to make an inquiry to us if anything, raises any legal issues for you today.
Fantastic. Thank you for that, Dan. That's excellent. And that okay, so that's a really nice lead into our first sort of pause for breath. And so recognising that hopefully what we've been discussing has prompted lots of questions for you already. So we'd really just open the floor to you as participants of the call, and if you want to either just pop any questions that you've got into the chat, or either just come off mute and ask any questions that you might have. So I'll just pause for a minute, and please ask any questions you might have. We haven't not been able to ask any questions yet, but we do try and test us. Welcome any questions.
Yeah, Jay, it's Aaron from the South Coast Aboriginal Medical Service. How are you, mate?
Yeah, hello, Aaron. Thanks for joining us.
Yeah, pleasure. Look, just a quick question in relation to the risk assessment side of things. And I've missed a few of the sessions, so I'm sort of catching up here. Just, I guess where we are with our risk assessment for the management plan is more towards having a risk assessment that basically, how would I word it? It basically supports our decision around a staff mandated vaccination policy for our staff, particularly our staff that are in DCJ funded programs. Is that consistent with what you're seeing across the sector in regards to these risk assessments, or are we sort of veering off track here?
So one of the things that I would be thinking about in response to that, Aaron, is it a proportionate response to have mandatory vaccination for your workers for the nature of work that you have? So I know, Dan, this is something that we've been talking a lot about from a legal perspective. Perhaps if you could, give some guidance here, that'd be really helpful.
Yeah, Aaron, did I hear correctly that it's a health service that you're representing?
Sorry, mate. Yeah, so I work for the Aboriginal Medical Service. So we provide, we're obviously an AMS, but we're also funded through DCJ for child protection programs.
Yeah.
So we're a bit of we sort of get it from both fronts in regards to, it's mandated for our health staff, our GPs and our nurses and whatnot. But then the other side of it is for our DCJ funded staff who interface with DCJ staff. Quite often, we've basically gone through a risk assessment process and determined that was an appropriate response, purely because the other side of that too is our DCJ funded staff are constantly in our clinic with our health staff. So it's about trying to protect as many staff members and clients as we can as well.
Yep. Yeah, thanks, Aaron. And I think I need to be very clear with my legal advice disclaimer here that I'm not advising your organisation what to do, but the starting point, yes, would be looking at the public health orders, and there is very clear mandate on healthcare workers as well as other types of workers in education facilities. So where it's prescribed by public health order. It's the kind of the easiest situation for the organisation where you have to mandate it. There's no choice. Where a public health order doesn't apply, and perhaps for the staff that are carrying out projects and programs through DCJ, the notified policy is inviting you to perform your own work health and safety assessment. So you're looking at all the factors, that the nature of the work that you're doing with vulnerable community, the nature of the workplace, the prevalence of COVID in the community. Would it be reasonably practicable to require all staff be vaccinated? And the answer is most likely. Most community organisations in the health setting, I think, could mount a fairly strong argument about why it would be a reasonably practicable control measure. So it's difficult to speak to sort of the whole sector. And on these calls, we have heard organisations fall on the spectrum, but from the information that you've said, I think there'd certainly be factors that would underpin a mandatory vaccination position for your organisation. But I'd encourage you to sort of contact us if you wanted that specific advice.
Yeah, thanks for that, Dan. And I think, Dan's put that link. So I'm just going to Aaron, just put you on mute for a quick second, and I'll ask you to unmute in just a moment because I was getting some feedback. I was saying, Dan's put that link in. Aaron, does that answer your question, or?
Yeah, Jay, that's really quite helpful. I was of the opinion that I think we would have a strong case if we ever had to, I guess, answer as to why we have gone down that path. And I can appreciate that, it can't be specific to our situation in regards to the advice, but it is quite helpful. So thank you.
Lovely. Thanks for that, Aaron. That's great. We've got another question, which I'll come to just a sec. Sophie, just wanted to just check, did you have anything to add to what Dan had said, or?
No, not really. That's exactly our position as well. It's each circumstance is different. Obviously there's some situations where vaccination is the highest control, high up on the hierarchy of controls, and would warrant vaccination, but it really does depend. There's so many different permutations and combinations it could change. I just note that Tamsin's put a question into the chat about what will be the definition of fully vaxxed with booster shots now being introduced. Now, again, with all of these things, it's the best thing to do is go to New South Wales Health. New South Wales Health at the moment, two doses of a vaccination is considered to be fully vaccinated. But I guess that, things could change going forward. I don't know the answer to that as well. So what I do, both as working in DCJ, but also as a citizen, I check the health website regularly. But at the moment, the fully vaccinated is 2 shots of an approved vaccine. Yeah.
Yeah, thanks for that, Sophie. And again, just to add to that, and again, I can't speak to what New South Wales Health will put out in years to come or in months to come. What I can say is that certainly from all the research we've been doing as a healthcare consultancy, is that you do see quite a waning of vaccination effectiveness and your effectiveness and your immunity levels after the second vaccination. The evidence has moved around a bit as we've got larger sample sizes, but it appears that AstraZeneca, the vaccine, the effectiveness against COVID drops off a little bit quicker than Pfizer. And Naomi, I can see you've got your hand up. We'll come on to you in just a second. So I do think that given that we do know that vaccine effectiveness does drop off after that second dose, generally everything I've been reading suggests that the third dose will prove to be quite important in the overall vaccination schedule, and will be something that will need to be thought about quite carefully. Obviously, the current situation is that you're not eligible for a third dose until 6 months after the second dose. But again, that could change in future. So we've got quite a lot happening at the minute. But I think the question is a brilliant question because it's highly likely that there will be changes to this. as in future. I think we need to. I think it's my view is that it would be unlikely that in the future just having 2 doses will continue to be sufficient. I think I would, if I was if I had to make a prediction, I'd say that probably 3 doses would become a requirement down the track. And of course, over the months and years to come, what will then happen is it will then go from being eligible from under 12s to under 5s. And then ultimately, the anticipation from all the health advice that we've been, and the experts in our network, is it will then move into the child vaccination schedule. And so that you can anticipate in future, it will be just a part of childhood vaccination. So Naomi, you had your hand up a moment ago. I'd love to hear your question.
Yeah, it was in relation to response after post positive case. So the current steps are to contact the local public health unit, and indeed that's what we have in place from an organisational perspective. And however, our last suspected case, we contacted the local public health unit, and understandably they're quite overwhelmed, and so we've had to place a contingency plan in terms of not being able to get through and communicate updates. But I just had wondered from a department perspective, what are the recommendations around not being able to get through to the public health unit?
Yeah, so I think that's a really good question. In the guidance that we put out and in the previous SHS guidance, we had a series of flow diagrams about what to do in different circumstances for confirmed cases and for suspected cases. And I think one of the key things from memory is that if you aren't able to get hold of the public health unit, then it's a bit similar to the guidance that Dan was given earlier. You should sort of assume that if you've got a suspected case, that you have to almost treat it like a confirmed case. So it's always best to err on the side of caution, these situations. And so it's better to, assume that they're a confirmed case and work it in accordance with that. And also, the other thing I would note that is particularly as the case numbers increase, as you move into more open borders internationally and nationally, public health units will get more overwhelmed. That it's a finite resource, and so the situation you're describing is likely to become more likely. So I think it does, in your control measures, it is definitely worth thinking through not relying on public health unit contact tracing. And certainly I know a lot of organisations who found that they've been able to put far more quickly identify potential exposure just through internal records that they've been keeping, rather than relying on sort of contact tracers. So I think that's definitely something to think through from a risk mitigation. Is, for example, if you've got people working in office settings or whatever the environment is, if you're keeping any registers of who's in on what days and so on, and sign in logs, whether that's electronic, which is ideal, or even paper-based, that's a really useful additional thing to have in place. So thanks for this, Mika. So Mika's just popped up. So in the guidance, we have put through, provided some decision trees about how to manage. So if you do have a confirmed COVID case, so obviously the first thing is if someone's actually got symptoms, particularly if they're severe symptoms, then just call the emergency services. That should be the first thing that you do. Then, if it's the symptoms aren't so severe, you can see that, informing the public health unit and your DCJ contract manager is the next step. So DCJ so you should be doing that in parallel. And then, as you can see here, staying in self-isolation until the local health district has released the staff member, seeking medical attention if symptoms become severe. And then once symptoms have passed, then making sure that you put the appropriate things in place to release people from self-isolation, including cleaning and encouraging that staff member to actually continue all the good controls that you would have had in place already. Does Naomi, does that answer your question?
Yes, thank you. I suppose we've already placed a contingency plan, because I guess once the public health unit can't be contacted, that doesn't trigger other kind of steps, preceding steps, such as accommodation for the client to quarantine or self-isolate. But you know, on an organizational level, we've placed and put things in place, but I just wanted to get a kind of confirmation from DCJ as to whether, you know, that they're fine for organizations to just as best can kind of work around not being able to get in contact with the public health unit.
Yeah, and Sophie, love to hear, and I see Cassandra's put in some additional points, but Sophie, love to hear your thoughts on this as well.
Oh, look, I think Cassandra, the checklist that you have to assist them, SHS, to report to the public health unit or seek advice, and the link is helpful in that respect. I think certainly have a look at the guidance material and the flow chart that's in there, because that kind of outlines the basic process. But as we move forward, I am conscious that even now, isolation requirements for vaccinated people have changed from, some time ago, and things may change going forward as well. So again, everything is at a point in time and depends on our trajectory towards, I guess, recovery out of COVID, prevalence, and keeping an eye on what our health is advising in terms of contact tracing. But I hope that provides some sort of guidance.
Yeah, thanks for that, Sophie. And I think Naomi, what your question really highlights is the fact that, again, you're having to deal with this stuff in a real world where we've got processes, we've got what should ideally take place, but you talk about just the practical realities. If you can't get hold of the PHU, then, and it's like, it's not very helpful if the guidance says, go to PHUs. But I think what we said in the guidance is do that when they're clearly they're having to prioritise the resources. When you can get through to them, they're terrifically helpful, and I know they're fantastically skilled staff that are there. But if you can't get hold of them for any reason, then hopefully some of the other things that we put in place are things to think through. And I think it's also just something to think through your plans. Have a contingency in place about don't just have a plan. And I know you're not saying you do, but for any other providers, it's really important that the plan is we'll just call the PHU and work it out from there. It's have a think through what you might do if case numbers are actually increasing as well. So I think that's just good just general risk management. So
I guess the current kind of processes or decision trees are based on the assumption that you can get through to the public health units, but I agree. Increasingly, I think organisations need to put in place contingency plans should they not be able to contact those key contacts at certain stages.
Yeah, no, exactly. So great, really good question, Naomi. Yeah, thank you, Sophie. Any other questions at this stage? We've got a few more questions for you all, but any other key questions at this stage? Okay, so we'll just move on. We've got a couple of quite interactive. So we just and thank you. We just been really good flowing conversation. So a couple of things that we wanted to say just again to help generate a bit more conversation from the group. So when we think about some of the considerations and controls that we're putting in place for workers and clients, I think we've had a really good discussion already about the fact that we need to be thinking about staff, students, volunteers, clients, and some of the considerations around. And as we've talked about, obviously those people that aren't vaccinated, clearly there's a higher risk of COVID, both transmission and of risk of poor health if they are to get infected. But also we need to think about other vulnerable populations that we're working with. So that could be immunocompromised people, it could be older people, and recognising that if you're dealing with Aboriginal and Torres Strait Islander communities, obviously people even in their sort of 60s are considered to be ageing. And people with higher chronic disease and particularly comorbidities. So these are all the big risk factors. Well, there's some of the key risk factors that we need to think through. As we talked about, just generally what's going on in the community. So I think really good horizon scanning for what's going on in your local communities, and just watching the New South Wales website to see if you've had transmission. And also we know, particularly in the aged care from the early stages of COVID, there are lots of challenges where contract workers particularly were working in multiple different locations. So again, as the risk levels start going up, actually trying to minimise the level of cross what people working across multiple locations is good, because again, that's just making things a bit safer for everyone. So some of the control considerations, we've talked about many of these. The only things we haven't really talked about are some of the communication. And so particularly as we get into higher vaccination levels, once you start nudging into sort of 95% vaccination rate, then you're starting to get to a point where, whereas some people, might be quite vaccine hesitant, but you're getting into a group of people who I guess are potentially, have stronger views about not getting vaccinated. And so a lot of this is about having sort of non-judgmental conversations with with people, and really trying to understand why, what the rationale for those views are, so that you can start to kind of have good conversations. So I think I've had some great examples of organizations that have, through having a really inclusive conversation in a non-judgmental way, and really just asking for where people are getting their sort of information from, and really have been able to open up a good conversation that has, in a lot of cases, led to a good outcome in terms of people being more open to vaccination. And that it's really important to note that, particularly on social media, there are just so many just dark places on the web, and so much misinformation that's out there. And so a lot of the times that people have seen it on Facebook, and they trust it. A lot of people trust a lot of the things that are out there that are in a lot of cases just fear mongering. There's all sorts of weird, wacky stuff out there. But if it's been passed on to you from a friend or colleague that you trust, then it's easy for this stuff to become believed. So I think that's something to think through. And I think, we talked about sort of staggered working. I'm sure many of you are all across having like A and B teams is something, again, as your risk levels go up, thinking about having potentially separate teams. So if one person is suspected or confirmed case, you don't lose your whole team, but also staggered rostering as well, and ensuring that people aren't coming into contact with each other as they're changing shifts and things like that. Okay, so a bit of food for thought there. We also note that there's a whole range of client groups with a whole range of specific issues. And I know, for example, in Western Sydney, when there was lockdowns, there's a lot of challenges about making sure that information was being made available in a really accessible way, particularly for people who from culturally and linguistically diverse backgrounds. So really important about making sure that you've got access to the really good information in appropriate languages and so on. And there's a lot of nuance to some of the issues with the sort of wide range, where we had a number of conversations around things like domestic and family violence, and so noting some of the challenges, and I think particularly around privacy and whether or not someone might want to share their details, if they are in that situation. And again, just recognising that as things are opening up and we're moving into the Christmas period, so the Christmas period is a sort of a known point, a potential crisis point, or a point of increased level of crisis for things like domestic and family violence. So some of these issues we need to be mindful of the time of year we're moving into as well, as that interacts with more borders opening up. So hopefully that's kind of food for thought, and that's kind of brought a number of issues to the front of your mind. I wanted to ask a question to the whole group. This is an opportunity for us to sort of share some good practice and experiences that we've all had. So what are some of the top risks that you're seeing in your services, and which controls have been most effective? So yeah, we'd love to hear from anyone on the call about some experiences you've had in your service and what you might have been able to do to effectively mitigate some of those risks. So yeah, so thank you, Annika. I see I work on an Aboriginal community where we have an office and a space for community use. Our elders are vaccinated. There are a small majority of community members who are not. Or we had to let a staff member go last month as she didn't want to be vaccinated. As long as they use the QR code, wear a mask, sanitize and distance from each other is okay. Is it okay for them to utilize the space? So Annika, love to just maybe tell us a bit more about like, your situation. Could you come off mute and tell us a bit more about that? Oh, sorry, I don't think you can find. I've asked you to unmute, but no dramas if you can't find the button. So, I think there's a couple of. Oh, sorry, yeah. Go for it, Annika.
You're talking about Liz. My name's Liz.
Oh, sorry, Liz. It just says. I'm so sorry, Liz.
No, Liz was the past manager.
Yeah, that's not the first time that's happened on these calls. Liz, lovely to have you on the call.
So what it is the worker that we had to let go is actually the youth worker. So that's where we're getting the DCJ funding for that program. So that's one of our problems. She didn't want to be vaccinated because she's Christianity.
Yep.
Which is ridiculous. So I just wanted to know, people that come here, we sort of don't know who's vaccinated and who's not. I don't want to be disrespectful and, start getting on people's backs about asking them whether they are. I don't know, because some people they might feel a bit offended that I ask them that. And plus, living on community, I'm working on community too. You see a lot of teenagers walking around on community, and I'm just a bit worried too that they're probably not vaccinated as well. So that's another concern here.
So Liz, yeah, thank you. Really, really good questions here. And Dan, I'd love to get your perspective on some of the issues about whether or not you can ask people if they're vaccinated or not.
Yeah, and Liz, I'll respond in a bit of a general way, but I do want to say that we do provide priority support to community-controlled organisations. So please do make an inquiry to us. I'll drop the link again.
Yeah.
I guess when we talk about, we need to be careful to not talk about staff and members in exactly the same way, because we need to treat them, different rules apply. So for staff, there might be rules under a public health order that explains that, we need to mandate vaccination, or we might perform a work health and safety assessment and say, our staff need to be vaccinated. Now, clients and service users is very different. So we also need to perform a risk assessment, and organisations have the right to sort of say who comes in and outside of the organisation, but we need to look at what is reasonable in the situation. So we look at government advice, for example, and DCJ have said they don't want essential services to close to unvaccinated community members, especially vulnerable community members. We also need to think about, what does our organisation exist for? So if we're there to service young people, we can't just close our door to unvaccinated young kids. So we do have the right to ask for vaccination status. So we might say, are you vaccinated when you walk in the door? But the organisation needs to think, well, they need to consent to providing that information if we're asking it. And if they say, no, I don't want to tell you, then we need to think about what other safety measures can we put in place to make it, to just continue service delivery, but in a way that protects your staff. So that's when we look at things like could we potentially provide that service outside, or are we going to ask our staff who are working with young people who are probably unvaccinated to wear some sort of PPE? So you can ask the question, but it's about the other control measures that you'll put in place. But I'd love to, I'd love for you to make an inquiry to us to explore some of that in a bit more detail.
Yeah, because we've got like a Christmas party coming up in a couple of weeks. So they've asked that people or parents be vaccinated, and because they can't enter the pool for this, we're going to have a pool party. So that's the concern as well.
Yeah, absolutely. Big events definitely will have to come into your risk assessment. I think that's, you can see the greater risk there. So how we manage that situation is really important. We think about it beforehand. Yeah.
Thank you.
Thanks. Great question, Liz. So yeah, any other experiences people like to share? I might just move this one more question. I'm just going to ask just as we move into the last 5 minutes. So there's just thinking as we're going forwards, as we move towards living with COVID-19 and the fact that we might see increasing and decreasing rates, how will the risk controls change for your organisation? Jenny, I just saw you'd come off mute. Did you have a question or a point to raise? No, that's fine. So anyway, if anyone else, would like to respond to that.
I'm happy to go. I'm Anna from the Infants Home. We have a postnatal health home visiting service, seeing parents with children birth to 5-year-olds. And the biggest change going forward will be that once we've got our risk assessment completely up to date, we'll be back home visiting, because that hasn't been on offer for most of this year. It's all been done by telehealth. So but depending on what happens, if vaccination rates change or cases grow in the areas that we're going to, then we'll have to pull back on that again. So it's, yeah.
I think that's a brilliant example. And yes, obviously great news that you're going to be able to get out face to face again. And I think that's the key thing to the risk assessment and the business continuity plan that goes with it, is almost just thinking through what would be the triggers that might lead you to having to potentially either scale back or even stop face to face again. So you kind of almost can preempt some of those situations before they come to pass. So yeah, but thank you for sharing that. That's excellent. Great. Okay. Well, we're just in the last few minutes of the call. So I'm feeling like we've got to most people's questions. So I'm feeling pretty good that we've had a good conversation. And I guess as we're moving into the end of the call, I'd just really like to just say a huge thank you to everyone for taking the time out of your busy days to join this session. We really hope you found it useful, and we hope you found all the range of resources that we've been posting in the chat and that are available on the DCJ website, and indeed all the other websites that we've linked to from there. We hope you find that useful. Before we wrap up, I wanted to thank Mika from Rebec for co-presenting. Dan, thank you from Justice Connect for your, as ever, brilliant gems of wisdom and level-headed advice. And Sophie and your team, again, huge thank you for your support to this and for sponsoring this session. So Sophie, I'll leave it with you to kind of have the last word.
Thanks, Jay. And I guess I really wanted to say this is the final one of 7 sessions that have happened over the last 4 days. So they've been really ramped up quite quickly. So I certainly want to give my thanks to you, Jay, and Mika and Anna and Daniel and Alice from Justice Connect. Not all of them have been on this call, but certainly I think it's been fantastic putting this material together. And to the DCJ people here, that's great to have you supporting. But mostly I'd like to thank the participants in coming along and participating in these sessions. That's what they're for. They're for you to hear what we have to say, to be able to ask questions. So I really hope that they have been useful. The guidance material is all on the DCJ website, and the recordings of these sessions are on our website as well. Dan has put all the material that Justice Connect has put onto the website as well, and obviously can be contacted if you needed that advisory service from the Justice Connect not-for-profit law service. And obviously also, if you have any questions at all that still follow from this, please do contact us at the Partnership Support mailbox. Many of us, including me, have access to that mailbox, and we do endeavour to, if we can't respond immediately, we'll certainly take your feedback and we'll try and put them into FAQs, which we're continually updating on the website. So thanks everyone, really appreciate your time. Thanks Jay, thanks Mika, Dan and team, and hope you have a good rest of the Wednesday.
Have a great day. Very best of luck everyone with putting your plans into action. Take care everyone.
Bye.
Bye now.